very strong evidence that the vaccines has its own contribution to bring down the incidence of those diseases to the lowest as we go with a very good coverage. But the vaccine rate needed for herd immunity, and this is one of the terminology that we have to understand in infectious disease and family medicine, to protect our community, we have to reach certain levels. For example, measles up to 94%, diphtheria 85%, influenza, for example, 75%. So this is the target that we have to work hard to achieve in order to reach this target. But unfortunately, as I said from the start, unfortunately, the vaccine for adults is as poor as it is between 20 and 40%. And this will highlight the importance of call for actions for all of us as a family physician, practitioners, and even as a decision makers or a contributor for the organizations that can make the decision that we have to enhance. And of course, having this kind of problem, it has a multifactorial problem. One is the patient factors, that they are not participating as an active partners and understanding the role of the vaccines to curb the epidemic. The other factor is the physicians presenting the clinical inertia. We are reluctant to disclose the issue that related to vaccines while we are busy treating diabetes and hypertension. And also the healthcare system that have failed totally to bring the patient and the physician in a proper encounter to address that particular sessions of vaccination in a proper way. So the vaccination hesitancy, this is the terminology that we have to look into, and this is the delay in acceptance or refusal of vaccine despite the availability of vaccine services. So we have the vaccine, but we failed to make our patients accepting the vaccinations. And of course, if we just go through the spectrum of those patients who are accepting or refusing, so this is the accepting, they are ready, and those who are in red, they are refused. They don't want the vaccine and they don't trust it. But between the acceptance and the refusal, there are certain categories that we have to work on them by counseling and by certain interventions and measures. One is accepted but unsure, and the other one accepts some of the vaccine but not accepting the other vaccine. And they always say, I don't know, I have doubt in certain vaccine. But again, if you just go towards the refusal before it, there is a stage where they refuse but unsure. So these are the areas where we have to work hard and counsel and change the mindset of our patients towards the full acceptance of vaccinations. So this is the area which is related to patients regarding the vaccinations hesitancy. But there is another terminology that is related to us as a physician, which is vaccinations confidence. We have to be very confident about the safety, the efficacy, and the mode of administrations and the powerful of the efficacy of the vaccinations to tackle the diseases. Unless we are having this kind of level of confidence, we will not be able to convince the patients regarding the vaccination. So we should recommend the vaccine, and the professions should administrate the vaccine, even the doctors. We should, for those patients who are hesitant, we have to take this initiative. The process and policy procedures that should govern the practice of vaccinations, and there should be no missed opportunity. If a patient comes to the hospitals and he's due for vaccination and leave the hospital without having the vaccine, so he will be counted as a failure of the whole healthcare system, and this will be a missed opportunity that will be not forgotten and forgettable at all. So it's a matter of trust how we look into this. So just to conclude certain statements, I would like to summarize what I have said. The impact of vaccine during the past 80 years on reducing the incidence of life-threatening disease is very, very, very obvious. There is no doubt at all. Although the improvement in vaccine coverage, adult vaccination rate is still very poor. It's less than 40%. As the healthcare providers, our role to build the confidence and manage the vaccination hesitancy. So this is a vaccination confidence, and to tackle the vaccination hesitancy from the patient perspective. And motivational interview is a counseling model to tackle the hesitancy, and I will urge all of you to learn about the motivational interview that is pertained to convert the patient from the pre-contemplation to contemplation state in terms of vaccinations. We have to master the art of answering the questions parents and adults and may ask any vaccines. So prepare with whatever comes across you, any questions, you have to keep it in your mind to answer it with a very courageous way of confidence. To communicate the benefits of vaccines for all, we should reach the multi and the social media. So please, your role is not confined to the walls of your clinic or the boundary or the compound of your hospital. You have more role to be given to your community. So you have to reach to the community. And this is what I have done many years ago when I was in the rural area vaccinating very primitive areas and with a very simple people just to participate in the community. And then going through the social medias and even the TV and radio. So this is my experience, and I would like to disseminate it to you. Be more proactive and reach to your patients and people and the community and nation through this multimedia, which will sound and repercuss in a very positive way to manage yourself. So my final statement, ladies and gentlemen, I would like to say and remind all of us, as a physician, we play a vital role in curbing the vaccine hesitancy and promote vaccine confidence. And this is just only to do one thing, is to curb the preventable disease that we have to do. With this, I would like to thank you so much. So for the sake of the time, I hope that I didn't take much of it, but it was quite important for me to express myself in this kind of introductions. So I would like to introduce our first guest speaker, Dr. Sarah Al-Muammar. She's assistant professor and family medicine consultant at King Abdulaziz University Hospital, academic coordinator. She's assistant professor, College of Medicine, Imam Abdurrahman bin Faisal University, the MAM, Department of Family and Community Medicine. And she has a large working experience in many university hospitals, as well as Ministry of Health hospitals in different cities between the East and West region of the kingdom. And she has a good teaching experience, and I have no doubt, in fact, because I know I got the feedback from the students of Dr. Sarah. She has a very good teaching experience with undergraduate and postgraduate courses, and has a lot of professional and community memberships. And she has a great number of publications and research activities. So she's going to talk today about the epidemiology of meningococcal disease. On your behalf, ladies and gentlemen, I would like to thank Dr. Sarah for accepting our invitations, and I would like to invite you on the stage, Dr. Sarah. Thank you.
السلام عليكم جميعا. لازم أقصر على طولي. Okay, thank you, Dr. Ashraf, for the kind introduction. I just want to add one thing to your presentation. You said that adult patient has the lowest rate of vaccination. We had a flu vaccine campaign in the university, and we noticed that we have very low rate of vaccination. When we asked the patient who attends the clinics why you're not getting the flu vaccine, most of them said it was not offered by their doctor. So do remember, when was the last time you offered flu vaccine for a patient who came for just checkup, or a diabetic patient who came for refill medication? So this is actually very important. The reason why adult patients aren't getting vaccinated is actually us not offering the vaccine to begin with, not just them being hesitant to take it. All right, so beside this, we're gonna start with our topic. We're gonna talk today about epidemiology of meningococcal disease. We're going to talk mainly about the definition, risk factors, transmission, and then we're going to go to the epidemiology, whether it's national and international. All right, let's kickstart this presentation with basic definition. What is the definition of meningitis? It's very simple. It's just an inflammation of the meninges, right? The meninges is basically the cover of the brain and the spinal cord. There are two types of meningitis according to the CDC. It's infectious and non-infectious. Infectious meningitis usually is due to bacterial, viral, fungal, or parasitic. And non-infectious could be due to anything like cancer, drugs, or immune disease, head injury, or head surgeries. Now, the reason why I wanted to add this slide to this presentation is because a lot of people actually use meningitis to describe bacterial meningitis, or they use it interchangeably with meningococcal disease. So I just wanted to add this so we can know that there are different types of meningitis. They all can be serious, but the one that we're trying to prevent is the one that is most common, the one with the highest mortality and morbidity. Just to go over the type real quick, bacterial meningitis is deadly, it's spread fast, and it's a very important risk factor. Viral meningitis is actually self-limiting. It is actually more common than bacterial meningitis. However, because it's self-limiting, we don't usually have a specific vaccine for viral meningitis. I don't know if you know, but no one can get viral meningitis directly. If I know a patient who has viral meningitis and I need that person, I'm gonna get the primary infection. Meaning, if I have measles and it develops into viral meningitis as a complication, and I need that patient with viral meningitis, I'm gonna get measles. Whether it develops or becomes meningitis, that's up to the patient or the immune system. However, in bacterial meningitis specifically, Neisseria meningitidis, usually you're gonna get meningitis, okay? Fungal meningitis, thankfully, it is not common. It happens mainly in patients who are immunocompromised. Parasitic are actually it's deadly, but it's rare. Non-infectious is self-explanatory. So again, like we said, there is a difference when we say meningitis, it's any inflammation. It just describes the inflammation of the meninges. Meningococcal disease is defined by the CDC as a disease that is caused mainly by Neisseria meningitidis, which is the meningococcus bacteria, which is a gram-negative bacteria. Now, the meningococcal bacteria or the Neisseria meningitidis has 12 serotypes. These serotypes is indicated or based on the polysaccharide capsule that each type has. We have 12 serotypes. However, the one that cause most invasive meningitis or septicemia are serogroup A, B, C, W, X, Y. It sounds a lot, but it's really, really important to know the types, and I'm gonna get into it, inshallah. Okay, so I always like to go back to history. How old is meningitis? So according to literature, meningitis is actually as old as the 1800s. The first epidemic meningococcal meningitis outbreak was first recorded in Geneva, and afterward it spread to Europe and the United States. In Africa, the first outbreak was described in the 1840s. African epidemics became much more common in the 20th century. Now, why am I asking how old is meningitis? Why are we here talking about meningitis? As a disease, a bacterial disease that started in the 1800s, and we're still having epidemics of that disease, okay? So this takes me to my next slide. What is the impact of meningococcal disease? Meningitis due to Neisseria meningitidis tends to strike young and well individuals, which means they're not immunocompromised necessarily. They're actually healthy people, okay? At the same time, it can progress over a matter of hours to death. Like we said before, it could be deadly with the appropriate antibiotics. So mortality can be very high if the infection is not treated appropriately, and long-term sequelae can be severe even in successfully managed cases, which means even though it's an infection that we have antibiotics for, you can still get the complication even if you were treated properly. What are these sequelae? 10 in 15 in 100 people, 10 to 15% in 100 people, 10 to 15 in 100 people, which is 10 to 15% basically, with meningococcal disease actually will die. In those who survive, 5 would have long-term disability. Again, according to the CDC, the most common disability or sequelae of meningitis is amputation and skin necrosis and septicemia, then followed by deafness, nervous system problems, and brain damage. So even if you treated that patient, you're gonna still have some sequelae, or it's possible to have some sequelae. And that's why it's very important to focus on the prevention part. I cannot just say I can treat it, I don't care to prevent it. The burden of meningococcal disease. The mortality and morbidity from meningococcal disease has changed very little since the 1950s, principally due to the inability to effectively manage the endotoxin produced by the bacteria itself. So mortality rates in patients with meningococcal meningitis, approximately 10 to 15%, as we said before. In the US, they did a population-based study that included all ages. They found the overall mortality for meningococcal disease to be 7%. I know 7% sounds little, but it's considered high for a bacterial infection. Okay, so which takes us here. What is the risk? Who can get meningitis? First of all, they noticed that certain ages are more likely to get meningitis. For example, children who are less than 2 years, they're more likely to get meningitis, which is why meningitis is there in the Will Baby or in the vaccination for children. Then we have adolescents and young adults, usually from 16 to 23 years old, and older adults over 85 years old. However, any age can get meningitis, but these are the ones that usually at risk. I'm gonna ignore the group for now. I'm going to go to the certain medical conditions. Some medical conditions are known to be to develop more risk for meningococcal disease, like the complement deficiency. The complement deficiency could happen either due to genetic disorder, like a family history, a person would have it, or the patient would take medication that would cause complement deficiency. Then also HIV patient due to immunocompromised state, functional or anatomical asplenia. If you're a family physician and you have a will baby visit or a child the clinic, you'll see patients who are 12 or 13, sickler, they will come for the vaccine, and it's mainly PCV and meningococcal vaccine, right? Now let's go back to the group setting. Group setting, basically any place where a lot or a group of people are in the same place, they're usually using the same amenities, same bathroom, same bedding, same towels. Chances are that in this group setting, you might have meningitis or you have a risk of developing meningitis. College students are one very important topic, specifically freshmen who live in dormitory. Again, this is important for family physician. Most of us actually signed the health clearance for people who want to, for example, study abroad in North America or in Europe or even in East Asia. Most of us would usually give the quadrivalent vaccine for meningitis. However, if I didn't know the serotypes, if I didn't know what's common, I would not be able to completely protect the person who came for the vaccine, okay? A good example of that, usually when patients come to our clinic, we give them the quadrivalent vaccine, which protects against A, C, W, and Y serotypes. It doesn't actually protect from the B serotype. But most patients who come asking for the vaccine, they're going to North America, where serotype B is actually the most common cause of meningitis in this age group. So it's very important to know that when I sign the health clearance, where is he going? What is common there? Is he really protected or not? Okay? Okay, so this basically says that before the quadrivalent vaccine, C was the most common group. But after introducing the vaccine in 2005, they have noticed that serogroup B actually became or had higher incidence. All right, what are the other risk factors? Traveling to meningitis belt in sub-Saharan Africa is a risk of meningococcal disease. So basically any place that have high incidence or has an endemic of meningococcal disease. One of the travel risks is actually Saudi Arabia during the Hajj season is also considered a high risk for travel. Occupational hazard like microbiologist and a healthcare worker like doctor, nurses, all are at risk of developing or having meningococcal disease. Finally, the intimate contact cases, and this is the highest risk of them all. If you have any intimate contact of a case who has meningitis, then the chance of getting meningitis is actually very high. And this is, again, very important, not because of the vaccine, but for the chemoprophylaxis. Because if now I know that that person knows someone or has been with someone who has meningitis, I need to give him prophylactic antibiotics, all right? Again, to prevent the disease. All right, let's go to transmission. How is meningococcal disease transmitted? It's basically transmitted through respiratory and throat secretions. So coughing, sneezing, any close contact like kissing, all will cause the spread of the disease. Then we have, and these are honestly the most dangerous one, the asymptomatic patient. So you'd have a lot of patients, specifically those who come from an endemic area, they're not gonna have any symptoms, none whatsoever. He's gonna travel, he's gonna spread the disease, and even if he comes back, you would not know you've been with a contact because he's asymptomatic, all right? And finally, humans are the only host. So no monkeys, no bats, no nothing. Humans are the only host. The average incubation period is 4, but it can range between 2 and 10. And again, we have to emphasize on the chemoprophylaxis. If I know he knows someone with meningitis, I need to treat fast because he can get meningitis starting day 2 or day 4. All right, let's get to the boring part. The epidemiology of meningitis. So Neisseria meningitidis can cause both endemic and epidemics. It's usually present and as an endemic, and when the number increases, all of a sudden they call it an epidemic. Meningococcal disease occurs worldwide, with the highest incidence disease found in the meningitis belt of the sub-Saharan Africa. Does this have a pointer? Okay, so anyway, you see this green highlighted area? This is the meningitis belt. It starts from the Senegal all the way to Ethiopia. If this worldwide, this is the highest place where there is incidence of meningococcal disease. So in this region, major epidemics occur every 5 to 12 years, with attack rate of 100,000 per 100,000 cases. Other regions of the world experience lower overall rates of the disease. In the meningitis belt, serogroup A historically accounted for 9 in 10, which means that if you have it, you're going to assume that it's serotype A. But what happened is that they introduced a vaccine, a monovalent vaccine for serogroup A, and the rates of serogroup A actually decreased, and now the one that is most common is C and W. All right. In Europe, Americas, and Australia, serogroup B, C, and Y together occur for the large majority of cases. The majority of invasive infection in England and Wales are actually caused by group B and C. In the US, the highest case fatality ratio actually occurred with W and C. As for the prominent serogroup, it's usually divided equally between C and B and Y, 1/3 for each. All right, so there's a study in the US that was done. They wanted to see the serogroup related to age and the gender. So they noticed that serogroup C, Y, and W caused 73% of cases among individuals more or equal to 11 years of age. Serogroup B caused almost 60% of diseases among children aged 0 to 5 years. Okay, so when they're children or less than 5, I'm going to focus more on serogroup B. If they are older than 11, then it might be C and Y and W. The highest incidence of disease occurred among infant, 2 to 3 months of age. The highest mortality occurred in patients over 85. So it happens more in children, but the one who dies from it are actually elderly. Meningococcal infection displays seasonal variation in attack rate, which is highest in February, March, and lowest in September. Again, this is mainly in the US. And in Africa, it was more related to dust and dry seasons. All right, so you can find this map in the World Health Organization, WHO. It's let's say a summary of what is common, which serogroup is common in each part of the world. You can have a detailed map as well. This map was published in January 2020. However, it's the data from 2019. You can go to WHO whenever you have a patient who wants to visit any place. You just go there and see which serotype is common so you can give him the proper prophylaxis or vaccine. So just to summarize, this is the most common serogroups. We have A and C, they usually happen together. It's the most common in Africa. Africa, parts of Asia, South America, and other countries from the Soviet Union are caused mainly by serogroup A and C. As for serogroup W, reports represent one of the less common serogroup in meningitis, responsible for many cases among pilgrims returning from Hajj in Saudi Arabia. So Saudi Arabia had an outbreak in 2000 and 2001, and it was caused by serogroup W. More likely to cause meningococcemia or septicemia. Outbreaks of meningococcal disease have been also reported in men who have sex with men, and this could be related to the fact that usually they group together, or the HIV infection that is common in that group. Finally, serogroup B is a relatively low incidence rate. The incidence was notably higher in Australia, Europe, North America, and South America. The sub-Saharan Africa almost has absence of disease. All right? So if a patient wants to go to Africa, you don't need to offer serogroup B. Okay, now we're done with international statistics. Let's go to Saudi Arabia. Now, as we know, the annual Hajj pilgrim has been associated with outbreaks of meningococcal disease due to serogroup A and W. Pilgrims are required by the government of Saudi Arabia to be vaccinated. Now, this is the health requirement and recommendation for travelers in 2022. It says the first one was COVID, the other one was meningococcal, and it was the quadrivalent one. So all traveler, domestic or international, adults and children aged over than 1 year, arriving for Umrah, Hajj, or to work during the Hajj season, they have to be vaccinated. Okay, so even if they are Saudi, they're still gonna offer the vaccination. If you notice, this vaccine will cover serotype A, C, Y, and W. Serogroup B is not covered, okay? Okay, to be honest, I didn't find a lot of studies in the CDC or WHO about the incidence rate or the yearly rate of meningitis in Saudi Arabia. However, we found a narrative review done by Dr. Murad Dabbagh and colleagues. It's the epidemiology of invasive meningococcal disease in the Kingdom of Saudi Arabia. I'm going to go over just the highlights. So this narrative review describes the epidemiology of IMD in case A from previously published national surveillance data supplemented by, I cannot read that one. More recent data. Okay, so basically it was supplemented by the old data and then they added their own data starting from 2012 and 2019. They introduced the immunization led to substantial decline in meningococcal disease in 2002. We did not have any outbreak after 2001. From 2001 to 2011, 184 cases were reported, chiefly due to meningitis W and meningitis A and meningitis B. So even though patients were vaccinated or required to get vaccination, they still have some W and A serotype and the meningitis B. Between 2012 and 2019, 44 cases were reported, although serogroup data are limited. Sporadic disease due to MenB and MenW is reported. All right. Appraisal of available surveillance and data indicate that existing surveillance system could be strengthened. Like we said before, we know that this patient had meningitis. We usually don't have the serotype as a data, so we can know which vaccination we should offer or make as a regulation. All right, as a disease to meningitis B remains a potential risk because again, it is not covered in the vaccine that is required. Preventive measures by the Saudi Ministry of Health is mainly by adding the vaccine and making it mandatory for all people who wants to come to Hajj or Umrah. Okay, so what are the global public health response? So we said that meningitis is a serious problem. We have preventive measures. What did we do to prevent or to decrease the epidemics of meningococcal disease? The WHO has endorsed a surveillance strategy to predict epidemics early and initiate vaccine. So what they do, they have a case definition. For example, they say if in one city we have 10 cases or 15 or 20, it depends on the definition by each country, they're gonna make a national vaccine program or campaign. The CDC responded in Africa by leading an international consortium called the MinAfriNet in collaboration with the WHO, African Ministry of Health, and other partners. What they basically do is that they do surveillance. They see which is done. They do surveillance. They see which cases are more common and which vaccine they should give. Meningococcal disease is reportable condition in all states. Maybe the ID can tell us if it's reportable in Saudi. This is the webpage of minafri.net. The MOH response was is basically the vaccine so far. We still want to have more surveillance so we can actually apply a better or more preventive measures. To summarize, meningitis is a serious disease. It could happen to anyone at any age. Mortality is very high. The epidemics still occur at irregular places, specifically in sub-Saharan Africa. There are 12 serotypes, A, B, C, W, X, Y are the most common. National health surveillance system is required. Physicians should check the epidemiological trend in each area in order to offer a preventable measure in the community. And that's it. Thank you.
Thank you so much, Dr. Sarah, for this wonderful presentation, which was quite illustrative, shedding lights on the epidemiology of meningitis, which I learned a lot personally, to know more about meningococcal. So we are going to introduce our next guest speaker, Dr. Muhammad Sadiq Samanoudi. He's a consultant internal medicine and infectious disease, transplantation infectious disease, King Fahd Armed Forces Hospital in Jeddah. He is assistant professor, Department of Medicine, Faculty of Medicine, Al Qura University, Mecca. And he has a fellowship of transplantation infectious disease, University of Texas in Houston, Texas, and American Board of Internal Medicine in Infectious Disease certified. And he has a fellowship of the Infectious Disease, University of Texas. He received a lot of awards, and the latest one was the ID Bug Bowl competitions in Washington, D.C., and awarded the first place in University of Buffalo in Research Symposium. So he has a great number of publications and research activities, and we are really very privileged to have Dr. Muhammad along with us today. And the topic is going to be the continuation of the epidemiology to another step to learn more about the management and the prevention of meningococcal disease. So on behalf of all the attendees, Dr. Muhammad, I would like to welcome you on the stage. Thank you.
Assalamu alaikum. I'm very happy to be here in this symposium, and I hope you enjoy with me the lecture. So today I'm going to talk about the management and prevention of meningococcal disease in adults. Our outlines today, we're going to talk about the microbiology, we're going to talk about the pathobiology, the empiric treatment in any patients with meningitis, then the targeted treatment for meningitis. Also, we'll talk about the role of corticosteroids in meningitis. And at the end, we'll talk about the prognosis and the prevention of meningococcal disease. So we start about the microbiology. Neisseria meningitis is gram-negative diplococci, which means gram-negative impairs. Serogroups, already Dr. Sarah talked about that in details. The other things, it's a fastidious organism, so it gets affected by the cold and the high pH and the drying, so the specimen transportation should be as quick as possible. Also, it's a colonizer in the throat, so this doesn't mean that the patient is infected, but if anything happens, if there is any inflammation in the throat, it can travel directly to the CNS and cause the disease. So what's the pathophysiology or the pathobiology? I want to stress on that system. We call it mannose binding lectin, the MBL. So once the serotypes of the Neisseria meningitis bind to that system, right away the complement pathways will be activated, and at the end we'll see the terminal complement C5 to C9. This is the responsible part of killing the Neisseria meningitis. So if we are talking about the inherited diseases of terminal complemental deficiency or acquired diseases that can cause complemental deficiency like systemic lupus, so this part is going to be affected, and that patient will going to be prone to have recurrence and disseminated meningococcal disease. So in any patient with meningitis, usually we start with the empiric treatment. But before starting any empiric treatment, we should ask ourselves, we should start it as quick as possible. So what is usually delaying that process? Getting a CT or not? This is the most important part. So first of all, we need to know, is that patient needs CT scan, like CT brain, or not? If yes, just do a stat blood culture, start the antibiotic right away. Don't wait for the LP. If this patient doesn't need a CT, do the LP, blood culture, then put your antibiotic right away on. Okay? So the antibiotic therapy should not be delayed while waiting the lumbar puncture. All the guidelines will say within 1 hour, IV antibiotic should be initiated. So what are the indications to do a CT brain prior to lumbar puncture? These are the different guidelines, the Infectious Disease Society of America 2004, the ESCMID guideline, the European one in 2016, and the UK. So usually we'll see they are like, the indication are very close to each other. Any focal neurological deficits, patients need a CT before the lumbar puncture. Any new onset seizure or seizure, the patient needs a CT prior to a lumbar puncture. Increased intracranial pressure in the IDSA. Any immunocompromised patients need a CT prior to the LP. So and decrease in the consciousness or in the Glasgow Coma scale, that patient also needs a CT scan prior to LP. Majority of these cases, we need a CT just to prevent like any brain herniation or any complication from the lumbar puncture. So I like this diagram. This is a diagram by IDSA guidelines in 2004. in any patient came with meningitis-like symptoms. So we have to ask ourselves, is this patient immunocompromised or having any history of CNS disease or seizure? The indication that we already mentioned for getting a CT prior to LP. If yes, do a blood culture, start the treatment right away. If no, we'll go with a CT scan. Then after the CT scan, we'll do the lumbar puncture. But while we're waiting, we should put this patient right away on antibiotic and dexamethasone. So just for that, the point is put the patient on IV antibiotic as soon as possible and don't let anything delay you from that. What are the appropriate antibiotics? So if the patient more than 50 years old and the patient immunocompromised, so the most appropriate treatment will be a third-generation cephalosporin, usually ceftriaxone. If ceftriaxone is not available, cefotaxime is an alternative, plus vancomycin and ampicillin and dexamethasone. Usually we use those 4 to target the most common bacteria that causing meningitis. Like for example, ceftriaxone and vancomycin, both of them to cover streptococcal pneumonia. Ceftriaxone alone to cover meningococcal or Neisseria meningitis. Ampicillin to cover listeria. And dexamethasone, we'll talk about it in the next few slides. But if the patient less than 50 years old, the risk of having listeria is low, so that we usually drop the ampicillin. So we'll just go with vancomycin and ceftriaxone and dexamethasone as an empiric treatment. At the end, there is an important point I want to mention. So positive CSF, a gram stain, this is an indication to de-escalate antibiotics. A lot of people, they miss this part. They wait for the culture before de-escalating the antibiotic. But having a positive gram stain, you can de-escalate the antibiotics. Like for example, we said meningococcus or Neisseria meningitis is a gram-negative diplococci. So once a CSF showed gram-negative diplococci, you can drop the vancomycin, you can drop the dexamethasone, and you can just keep the ceftriaxone alone. So this is the targeted treatment. So we can de-escalate based on the gram stain. Intravenous third-generation cephalosporin is preferred, either ceftriaxone or cefotaxime. Once we see this gram-negative diplococci, we can drop directly the vancomycin and the ampicillin and the dexamethasone and keep ceftriaxone alone. But what if the patient is allergic to penicillin? So if IgE mediated or non-IgE mediated, so IgE mediated, we can go ahead and start ceftriaxone because the risk of having a serious allergic reaction is less than 30%. And if IgE mediated, we usually don't use any one of the beta-lactams. So either cephalosporins or carbabinum or anything, we just go ahead and use fluoroquinolones. Some studies, they say, okay, the risk is less than 1%. Why we just use meropenem? Why we just use imipenem? Personally, even with less than 1%, I don't want to put this patient on anaphylaxis. So I would just go ahead and put this patient on ciprofloxacin or levofloxacin as an alternative for IgE-mediated allergic reaction to penicillin. So this is from the European guidelines in 2016 for Neisseria meningitis. We talked about the treatment. In Europe, they have a lot of cases penicillin susceptible. So penicillin in Europe, it exists. But if you see in the IDSA guidelines, they don't even mention penicillin. So in Europe, a lot of susceptible cases. In Europe, they don't have a lot of cases of MRSA as we have here. So the understanding the epidemiology there of the organisms is very important, so you can build your antibiotic based on that. So when we have an Neisseria meningitis, usually here in Saudi Arabia, I prefer just keep ceftriaxone until you have the susceptibility and then continue to treat this patient for 7 days, total duration of 7 days. And this is agreeing by all guidelines, European, American, and UK guidelines. Total duration of 7 days. What's the role of adjunctive corticosteroid, dexamethasone? So the dexamethasone, the role of dexamethasone, decreasing morbidity only on 2 organisms, streptococcal pneumonia and Haemophilus influenza. But how about meningococcal? Nothing. All the studies showed no any effect on the Neisseria meningitis. Other studies showed that there is increased mortality if you use dexamethasone with listeria and with fungal, like CNS cryptococcosis. The study was published in New England Journal of Medicine in February 2016. That study had to stop in the middle of the study for safety, for the patient safety, because the mortality rate was high. So fungal listeria, we have to stop the antibiotic for dexamethasone right away, and we keep dexamethasone only in two situations, in Streptococcal pneumoniae and Haemophilus influenza. How about the prognosis? So as Dr. Sarah mentioned, before the antibiotics, the mortality rate was very high, was about 70 to 90%. But with antibiotics, it dropped to 10 to 15%. Still, 10 to 15% is too high. So this disease is very aggressive and need the treatment to be started as soon as possible. So that's why we are emphasizing and stressing on the 1 hour duration. Less than 1 hour, we should put antibiotics on. Early antibiotic therapy associated with good outcome, and elderly age group with focal neurological deficit associated with poor outcome. Prevention. So in preventions, I would like to talk about the 3 major points here. Droplet isolation. Once you suspected that you have a meningitis or bacterial meningitis, it is better to put this patient on a droplet isolation in the first 24 hours from starting the appropriate or the empiric antibiotic. This will prevent the transmission of antibiotics in your hospital, transmission of the infection in your hospital. Number 2, you have to identify who are the close contact. So close contact, a lot of debate about that, but close contact defined as household members, travelers with a direct contact, exposure to oral secretion, like people who are doing the endotracheal intubation, respiratory therapists who are putting the oxygen mask on the patients, and the vaccination. So chemoprophylaxis, all the studies showed that the best outcome if started within 24 hours from the exposure. And these are the options: oral ciprofloxacin, 500, only 1 dose, intramuscular ceftriaxone 250, only 1 dose, or rifampin 600 milligram every 12 hours for 2 days. So if you look, you will see the easiest one is just to give an oral dose of oral ciprofloxacin, 500. I have some reservation about that, so you have also to know how is the resistant pattern of the Neisseria meningitis around you. So like in US, ciprofloxacin was great, so we were giving all patients ciprofloxacin. Here, cipro and ceftriaxone, they are good, so you can give either or. In Europe, usually cipro is a second line, so we usually better to give ceftriaxone as a 1 dose. So always try to know what is the incident and what is the resistant pattern of the meningococcus around you before putting your prophylaxis regimen. C5 inhibitors. So this is an important point that I would like to spot the light on it. So people who are taking eculizumab or revelizumab, and usually used for complement-induced hemolytic uremic syndrome or paroxysmal nocturnal hemoglobinuria, so they are at risk for meningococcal disease with 1,000 to 2,000 folds. So you can imagine it's a huge increase. So vaccination is a must. So no negotiation on that. But still with that, there is still increased risk. So a lot of expert opinions, they recommend to give this patient a chemoprophylaxis while on these medications. I was trained in a place who give oral ciprofloxacin 250 milligram once daily in any patient on eculizumab until they stopped it. Because 1,000 to 2,000 folds, that's a huge, that's too much. Vaccination, so we have 2 major types of vaccination: the conjugate, the one that can cover the ACWY, and MinB or the serogroup B vaccines. So the indication to give them, all patients from 11 to 12-year-old should get the MinACWY vaccine. then a booster at age of 16. But if the adolescents received it at the age of 16 or after, no need for a booster. And the CDC also recommend the booster dose for those increased risk to get an outbreak after 5 years, like patients going to for Hajj, patients going for the area with a meningococcal belt. So those people, they need to get the booster after 5 years. Min A, ACWY vaccines, high-risk patients, HIV, C5, C9 deficiency, either inherited or acquired, we talked about it, functional or anatomic asplenia, including the sicklers. So here we have a lot of sickler patients, and they are having functional asplenia. So those people, they need to get the meningococcal vaccines, C5 inhibitors, eculizumab and ravulizumab, traveling or residing in countries with a serogroup ACWY, or going to Hajj, microbiologists, military recruits, and in areas with outbreaks. This is, we already, Dr. Sarah talked about it, the meningococcal belts. So people who are traveling to this area, they are in a need to get to the vaccination before going there. And people who are at increased risk due to medical conditions like HIV, terminal complementary deficiency, asplenia, all of those people, people are taking C5 inhibitors. They need to get 2 doses of the primary series of meningitis ACWY with 8 weeks apart, then to repeat it as a booster every 5 years. Lastly, so all adolescents and young adults at age 16 to 23 may also receive serogroup B meningococcal vaccine. So in the CDC, they are making it like as a kind of optional. The ACWY is a mandatory, but B is like a kind of optional, but it's a must for terminal complementary deficiency, C5 inhibitors, microbiologists, asplenia, and in outbreaks. And usually we give it at day 0, then a booster after 1 year, then every 2 to 3 years. Okay, I guess I will leave the question part at the end of the symposium, and thank you.
Thank you so much, Dr. Mohammed, for this wonderful presentation that shed light on the management, on prevention of meningococcal disease. So we'll move to the third guest speaker today, Dr. Noura Al-Azhari. She is a consultant on pediatric infectious disease at Faqih Hospital, and we're really privileged today to have this kind of diversity of specialties, pediatric and adult infectious disease, plus family medicine. She is the director of pediatric residency program at Faqih Hospital, faculty member of Faqih College of Medicine and Science and Education, and she was awarded the best senior in pediatric residency program Faqih Hospital in 2017. She has a lot of contributions. She's a well-known figure. I don't have to say much about it because whatever I say, it will be not enough. So I would like to thank you for accepting our invitation, Dr. Noura. And I will just leave the floor for you for your interesting presentation about the meningococcal B vaccine and the real world experience. And this is exactly what we would like to learn from you today. Thank you.
Assalamu alaikum. This one? Okay. Assalamu alaikum, everyone. It's my pleasure to be here today and talk to you about a meningococcal vaccine. After this full and fruitful presentation by Dr. Sara and Dr. Muhammad and Dr. Ashraf, I think I will just highlight a little thing about the importance of vaccine. As you know, it's a devastating disease, and if you have the option to prevent it from the beginning, you will choose it, and you will provide to your loving one and your children the benefit of vaccine rather than to have the experience to go through this devastating disease. So as we know, invasive meningococcal disease, it is Okay. Sorry, but Doctor, this is not the updated one, I think. Okay, no problem. Can we share this one, the one in the computer? Anyhow, we will start as it's prepared. So, invasive meningococcal disease, it is caused by different serogroup, as mentioned by Dr. Sara and Dr. Muhammad. The most common serogroup is A, C, W, Y, and X, and B. The disease may occur sporadically or in cluster, or it can evolve in epidemic as it was happened before in outbreak in US, Canada, and also in Saudi Arabia. And as we know, vaccination is considered the best strategy to prevent this disease. The epidemiology, it was discussed thoroughly by Dr. Sara. It's in different places of the world, there is different serotype, and it's changing with the changing of the vaccine that it's developed by the company. And whenever there is an epidemic or there is an outbreak of any serogroup, and when the vaccine is developed, the serotype is changing and it's dynamic. Okay, no problem. We have figures, that's why I'm just waiting to show you the figures.
While we are waiting, I think it's nice to prepare the questions from the physical audience, because we have plenty of questions from the virtual audience. We are having now more than 2,500 attendees. So just engage yourself now in this couple of minutes just to think about the questions. Thank you.
So going back to our presentation, and sorry for this delay. So as it showed here in the map, the different serogroup according to the different situation, and it was presented clearly by Dr. Sara, but we can see here that it's changing. Like in Europe, it's more of B serogroup. In Africa, it's more of A and C, and also in South Asia, it's C and A. Okay. As we said that the serogroup distribution is dynamic and it's changing with time. We can see here in the United States in 2010, it was more of W serogroup and followed by C and then D. But in 2016,
But in 2016, now we can see that the B is more common in the United States. In Brazil, it was in 2016 also, the C group was more than in 2015, still the C and increasing the W type. In the UK, previously, it was mainly B, and also 2014, still B, but we can see that increase in W and Y serogroup. Coming to the Middle East, in the latest studies that was done in from 2011 to 2017 and 18, we can see that it's mainly, all the invasive meningococcal disease is mainly caused by serogroup B, contributing to more than 77% of the cases. In Iraq and Kuwait, in North Africa, Algeria and Tunisia and Egypt. Also in Europe, when they did this study, they found that total invasive meningococcal disease was caused by serogroup B, but it was mainly in the patient who's under the age of 1 year. This is the narrative review that was presented by Dr. Sara. They did the epidemiology according to the invasive meningococcal disease in Saudi Arabia. According to the serogroup, it was also in 2000 and 2001 in the outbreak, it was mainly serogroup W. After that, from 2002 to 2011, still there is serogroup W and also increasing A group and B as well. And it was found that most of the cases were either younger than 15 years or more than 45 years. And even after the vaccination that was implemented in 2016 of meningococcal vaccine, we're still seeing patients with invasive meningococcal disease, but it was decreasing than the pneumococcal. So this is the conclusion that invasive meningococcal disease still remain a threat, but with sporadic cases with mainly infant and children less than 15 years. And they conclude that we still need a good surveillance system with good reporting and intervention. This is the latest incidence rate of meningitis during the late 5 years. We can see here that it's decreasing, but still there. In the total meningitis, invasive meningitis, or the total meningitis case was 2,403 in 2016, but the latest in 2020, it was 107, with only one meningococcal meningitis, but this does not mean that we don't have meningococcal meningitis, because most of the cases, they reported as meningitis to MOH without defining the serotype of meningitis. Or most of the cases also, we don't have like a positive culture, or most of the institutions, they don't have the PCR or the agglutination test to do it for a patient who's having meningitis. That's why we can see that meningitis, it was reported with 107 without defining which type of meningitis. So, coming to the intervention that is done by the Kingdom of Saudi Arabia and MOH regarding the management of outbreak, it's usually depending on the epidemiology. They are changing the intervention and management according to the epidemiology. So we can see here in 1980, when there is an outbreak with meningitis A, they mandate the receiving of meningitis A vaccine, the monovalent vaccine. And also they mandate for all the comer and visitor from the meningitis belt to have a chemoprophylaxis to be taken before coming to the Saudi Arabia. And when the outbreak of 2001 happened in Hajj, they mandate after that the requirement. It was requirement to have anyone who's coming to Saudi Arabia or coming to the Hajj and Umrah to have the MenACWY vaccine. And now, as we said, with the changing the epidemiology, they are thinking also to consider the meningitis B to be part of the vaccine, especially for high-risk patients. And now the pentavalent vaccine under processing, which include all the most common serotype, including B, with the MenACWY. So coming to the vaccines, this is the structure of Neisseria meningitis with different antigen, cell membrane, cell wall, and the protein. So the MenACWY, it's containing the capsular protein polysaccharide, and also and it was conjugated to different type of protein, either tetanus toxoid and cross-reactive membrane of the diphtheria. The other vaccine, the monovalent, the one was before the AC to cover A serogroup. It was OMV, the outer membrane vesicles, and 4C Men-B, the new one for meningitis B, contained 4 types of protein. The factor H binding protein, 2 types, and an adhesion protein, and also portion of the membrane. And the other type of meningitis B, which contain 2 types of factor F binding protein. So the main vaccine that is available nowadays, we have 2, the monovalent and the 4-valent, the MenACWY, the conjugated one, and the meningitis B vaccine. We have 2 types. And the one available here in Saudi Arabia is the MenACWY. It was introduced in 2010, and for use in individual 2 to 55 years of age. The polysaccharide was the first one, and now we are using the conjugated vaccine. And since 2013, it was included in the National Immunization Program for infants age 9 and to 12 months. It is 2 doses giving starting from 9 months, and the second dose will be at 12 months. And recently also there is a recommended booster dose to be given at 18 years of age. So when talking about the effectiveness of MenACWY, this is a study was done. It's a case control study studying the 1 dose of MenACWY, comparing the one who's vaccinated with the group non-vaccinated, and it was shown that the MenACWY is preventing meningococcal disease was around 70% within 8 years of vaccination. After 8 years, it will be weaned by 1 year after vaccination, 70% after 3 years, and to 60% 3 to 8 years after the vaccine. This is the CDC recommendation for meningococcal B vaccine. They mentioned that the high-risk group, it's include infant younger than 1 year, adolescent, and young infant 16 through 20 years of age, and people with certain medical condition, the same as the one mentioned by Dr. Muhammad, people who have complement deficiency, or people who is taking any medication complement inhibitor, people that working in a high-risk area or hospital like microbiologists, or who's interfering with the Neisseria meningitis, and people who's living in a high endemic area. So coming to the experience of 4C Men-B vaccine, it is supported by data from worldwide experience across multiple settings. It was introduced in many cities in Europe and also in North America. The most important experience, it was introduced for all infants in UK in September 2015. The program used 2+1 immunization schedule administered at 2, 4, and 12 months of age. It was also co-administered with the routine vaccine. More than 300 million doses was administered, and more than 100 million infant children aged 2 to 18 months received the vaccine. The adverse effect was reported. It was only local reaction or fever, and it was managed by paracetamol, giving the patient even before they give the vaccine the paracetamol and explain to them. And there was no new safety signals identified, and they found also that there is a high compliance with subsequent doses and with routine vaccination. So at the end, they conclude that it has a favorable risk-benefit profile. And when they calculated the risk of having invasive meningococcal disease, they estimated that there is a 75% reduction of the invasive meningococcal disease in the first 3 years. And they estimated that 277 cases were prevented of having this disease. Another experience was also in Italy, in 2 cities of Italy. They also implemented MenB vaccine in the school age group, and starting from 2 months of age, and it was given in 2, 4, 6, and 12 months. And it was showed that there is the effectiveness of the vaccine was reached 93 and 91 respectively in these 2 countries. It was also, this effectiveness was measured by case control studies. Going to the MenB experience and outbreak, there was an outbreak in Quebec in Canada, 2019 and to 2011. And MenB was the main cause of invasive meningococcal disease with 61% of death. So they introduced the MenB vaccine in 2014, and the incidence was reduced by 96%. Another outbreak also was found in US in 10 universities, and it was also caused by MenB serogroup. 3 of the university, they introduced, 7 university implemented the 4C MenB during the vaccination campaign, and there was a reduction, a markedly reduction in invasive meningococcal disease was reported. And safety finding was considered with this vaccine. So overall, in summary, 4C MenB vaccine is safe and effective in different settings. Maybe we did not have this experience here, but they did it in Europe, where the MenB vaccine is already prevalence there, with high vaccine effectiveness and high vaccine impact. So, in summary, invasive meningococcal disease can range from non-specific symptoms to severe devastating disease, and also can lead to death within 24 hours. Saudi Arabia, as we know, have host more than 10 million pilgrims every year, and we are having from different parts of from the world, so we need to consider different serogroup to be covered. Current meningococcal vaccine not protecting against all serogroup, as we said that we have here only the MenCAW, but we don't have the other yet. MenB reported to cause disease in Saudi Arabia and the Middle East. And 4C MenB is supported by data from across multiple settings with significant impact and vaccine effectiveness and safety profile. So my take-home message: if you want to protect your loving one and your children, just provide for them and counsel them for the vaccine, and try to explain everything, as Dr. Amir told us in the beginning. Just take every chance to have a conversation or counseling patient or parents regarding vaccine. Don't waste it, and take the opportunity to prevent the infection. Thank you so much.
Okay, thank you so much, Dr. Noura, for the wonderful presentations. And I would like to invite all the speakers to be on the stage here so we can start the Q&A session, please. Dr. Muhammad, Dr. Asara, Dr. Noura, please. So, so to start with, we would like to open the floor now for the physically attending guests. So any one of you have any question? To answer your questions. Dr. Abu Nawas, yeah, he's the hero of the place all the time. Wonderful questions, very hot discussions. Yeah.
First, I think it's this sort of symposium. It's very, very rich. I think we're passing a very strong message all over, not on Saudi. My question, since we are passing through the viral age, so during we have the lock-in with COVID-19, so have we encounter any cases in Saudi Arabia, whether in pediatric or adult, and how could you manage? Thank you very much.
So the question is, did we encounter any new cases of meningitis in general or MEN-B?
In COVID-19.
During COVID-19, did we get any new cases? This is epidemiology. Anyone?
Thank you for your question, but I just want to clarify. So you are asking about meningitis caused by COVID, or meningitis caused by any bacterial infection in the area of COVID?
Since we are dealing with the COVID-19.
Okay.
Corona-wise.
Yes. So.
Okay, regarding pediatric age group, yeah, we are seeing a patient who's manifesting or presenting with a picture of meningitis. When we do the investigation, when we do the CSF studies, it is only viral. So we are concluding that this could be caused by meningitis with the COVID virus, SARS-CoV-2.
Yeah. Yes.
And also in the adult part, yeah, we are facing cases of CNS infection. I would like to call it like that because majority of times we found them to be like encephalitis. And the cases that I met, they were like severely encephalitis and ended by having mortality. Because the same thing here, we will start to treat for different kinds of encephalitis, and we will diagnose it by diagnosis by exclusion. So we will do all like PCRs, and we will do cultures, and at the end, if we couldn't find any cause for that, we'll call it this is most likely COVID-19 in acute setting of infection by COVID-19.
Yeah, I just want to add here in continuation of the same questions, because we have witnessed during the COVID era a drop in the incidence of many respiratory diseases that because of the use of all the protective measures, using the mask and sanitizations and this kind of culture which has been created during the COVID era, it has been impacted negatively or positively in having lesser incidence of those diseases. Do you think that this has been, encountered with a similar concept in meningitis?
Actually, the most important or the famous example for this situation is the influenza.
Yes,
So if we noticed during the influenza season, we didn't see influenza.
yes, absolutely.
And when we start to ease up the precautions, now the influenza cases start to occur. So yes, the impact of COVID precautions, we are seeing it.
Wow.
And even the epidemiology of the disease is changing.
Absolutely.
Usually October to March, but you are seeing influenza now.
Oh.
Yep.
Okay, thank you. Any other questions from the audience here? Because
I can
before we...
add also something. Also the respiratory viruses in pediatric, the RSV. We know since before that RSV starts from September to March. Now we are seeing RSV in summer. All the season, it has been changed. The geographic after the COVID area all has been changed.
Okay, we have a question from Dr. Abu Bakr. Thank you, Dr. Abu Bakr, for coming all the way from Medina. We are privileged to have you with us here as a guest invitee.
جزاك الله خير.
الله يعطيك العافية.
السلام عليكم ورحمة الله وبركاته وأسعد الله مساكم.
مساك بالنور والسرور.
الله يحييكم. ما شاء الله تبارك الله سيمبوزيوم فعلا ثري بالمعلومات الجديدة والشاملة. ما شاء الله لا قوة إلا بالله. I think in 1987 there was an outbreak in Hajj period, and I was there as a responsible man there. I was the director of communicable disease in Ministry of Health at that time, and we found a difficulty in using chemoprophylaxis for the Hajjis people and for other people communicated with them. And we started with actually rifampicin, 4 doses, 600 milligram. And we found difficulties the people not to complete the course actually, because you know the red urine.
Yes.
And we found also difficulty in talking with Hajjis in different languages actually at that time. So we did a study after Hajj period, exactly, at Hajj month, after Hajj, in Jeddah. We compare between 4 doses of rifampicin and 1 dose of intramuscular of ceftriaxone, 250 milligram, 1 dose only, for treating the carrier people in Jeddah. And we found that 1 dose of ceftriaxone, third generation of spalsporine, 250, is more effective or much effective than the 4 doses of rifampicin. And Ministry of Health at that time started to start 1 dose, one shot intramuscular of ceftriaxone, 250 for chemoprophylaxis for most of the people who attend the Hajj or coming from their country without vaccination or with vaccination, but we are not sure that they had the vaccine. So we give them also 1 shot, and that's it.
Okay.
Yeah, at that time.
Okay, thank you so much.
And the study was, I think, in Lancet at that time, 88 or, yeah, it was in Lancet on the first page. Yeah.
Right. Thank you so much, Dr. Abu Bakr. So this will bring us in synchronization of the same questions. It came to my mind because this is one of the questions which was asked by the virtual audience. The chemoprophylaxis, the use of chemoprophylaxis, did that was a major cause for developing a bacterial resistance, especially for meningitis, and having a new serotypes and new serogroups? Do you think?
Yeah, honestly, I'm not aware about studies talking about that, but the good part here that we are using the prophylaxis for 1 dose. So usually one dose, I don't think it's enough to cause like
Resistant.
a threatened resistance. Usually we need that stress factors to be repeated and repeated so the bacteria can understand how that antibiotic is working and develop the resistance against it. But I like the point that you mentioned. Personally, I like ceftriaxone. I'm a kind of OCD, so I don't trust, like if I give ciprofloxacin and let the patient go. No, I would like to give an IM ceftriaxone in front of my eyes.
Okay.
So because this is like the mortality is 10 to 15%. I don't want that to happen. I don't want like anyone tell me like, okay, I'm gonna take it, then he will not take it and develop meningitis. And this is all happened because of he didn't take the prophylaxis.
Okay.
That's my personal opinion.
Well respected, thank you. Dr. Sarah, the role of carrier asymptomatic individuals in disseminating the meningococcal infections.
Say it again?
The carrier asymptomatic individuals, what is their role in disseminating the infection of meningitis?
Well, if you think about it, patient who act, or people who goes to Hajj are physically well, and we still have outbreaks.
Yeah.
So the problem is you cannot screen for it. There are no symptoms. So being asymptomatic is actually more dangerous, and we're not going to take precaution. If someone has fever or he's sneezing, most of us will have or will take our own precaution. But if someone is symptomatic, then I think the chance of spreading is even more than someone who has an active infection. Exactly,
Yeah.
asymptomatic carrier. Yes.
Regarding the carrier states as well, the men CAOW, there is a study, multiple study that said that it will decrease the carrier state. Although the men B, they did not found any decrease of the carrier state of the Neisseria meningitis in the nasal flora.
Okay, perfect. I think, Dr. Mohammed, you have answered this question, which came. Can we treat meningococcal meningitis with oral antibiotics? You said your preference is the ceftriaxone injection.
Okay, that's a good question. So now the whole world is talking about oral antibiotics. We have the POET trial for the osteomyelitis, the POET trial, the European one for infective endocarditis. Majority of them, they said if you control the source, you can continue the duration of antibiotics by oral for osteo and infective endocarditis. I think with meningitis is a different situation due to the blood-brain barrier. Not all the antibiotics can pass the blood-brain barrier. Selective antibiotic can pass the blood-brain barrier during the inflammation, like vancomycin. Vancomycin is not a good medication for CNS, but when the meninges are inflamed, it can pass through it. I think in this situation, there is no enough studies to talk about oral in CNS infections. So usually, and up to now, IV antibiotics is the only recommended choices for that.
How about the meropenem?
Meropenem, we can use it, but the point that I would like to stress on it, meropenem is also intravenous, but the problem in meropenem is that if the patient has IgE-mediated penicillin reaction, like anaphylaxis, the risk to develop carbapenem anaphylaxis is less than 1%, and with cephalosporin, 30%. So cephalosporin is out, but how about carbapenem, less than 1%? I don't think I'm confident enough to put this patient at risk of anaphylaxis even with less than 1%. So stay away from meropenem in such cases, and I will go with fluoroquinolones. By the way, fluoroquinolones CNS penetration is excellent.
Excellent. Dr. Noura, if you just can highlight or brief us a little bit about the ACIP recommendations regarding the meningococcal vaccines.
Okay, regarding the ACIP is the Advisory Committee for Immunization Practice. This was regarding the ACW vaccine. It was recommended for from the age of 11 to 12 and 2 doses with different 8 weeks regarding the routine immunization. And for high-risk group, starting from 2 months of age to the high-risk group that was mentioned by Dr. Mohammed and Dr. Sara before, patient who's having complement deficiency, patient who's having who's on medication that inhibit the complement, like C5 inhibitor, patient with HIV, patient who's living in a high endemic area or at risk of having also infection in crowded area like school student or college student, military soldier, and also people who's working in hospital and has exposure, direct exposure to the organism Neisseria meningitis.
Okay, thank you so much. I think I have, hold on. There's a question here. Amin? Okay, hold on.
Okay. Thank you, Dr. Ashraf, for this club and this monthly meeting. But we are talking about how to manage the meningitis as a disease. If we want to make some awareness for the people, for the public, how can make it? What's the best way for the awareness for the people? This is my question, but I don't know who will answer.
Yeah. Well, we can work on, again, any problems in healthcare, we have to stratify it into certain segments. One is related to the patient, families, and community factors. So that's why we have to enhance the perceptions and change the mindset of those people from the negative attitude towards vaccine into acceptance and looking forward, to have these vaccinations. So this could be by the personal, person-to-person kind of advice, counseling, and this is one of the very important opportunity where the physician sits in front of his patients and try to convince them, because patients usually perceive the advice of the physician as a very important, advice that could change it, the better health of him. The other thing is the mass media and public media, campaigns, community outreach programs. So all these things are important, to get associated together to formulate this kind of change in the mindset. Again, the physicians, as we said, if we are, as a physicians, are reluctant to explore the vaccination, each single encounter with patients, we are not doing the best interest for patients. So that's why we should not have this kind of missed opportunity. And then the healthcare system, we have to have our unified practice governed by a system where there should be a vaccinations embedded within our consultation by law and by system. So we can enhance our electronic system as we have in many of the hospitals. Before you end your consultations, the system will highlight whether the patient has these kind of vaccinations, identifying, and we have to have some kind of system that can pick up those patients at risk for that vaccination, using technology and remote, telemedicines and reminder technology, to enhance this. So there is a lot of items that we can implement. And then the decision makers, they should make sure that this is the national health safety, the communicable diseases. And we have hit badly by the COVID, but alhamdulillah, we recovered as one of the leading countries in the globe to manage this crisis very efficiently. So I think now the concept towards the communicable diseases is much more better than it was before. We were focusing more on non-communicable diseases. Now there is, they always say the Chinese dragon, the return of the Chinese dragon. So we are having this kind of vaccine epidemics coming, and we anticipate it. So that's why we have to move that way. So if anyone would like to add anything. Okay, thank you. I would like to through the $1 million questions for all of you. Of course, we know that the MenB has a high prevalence across the globe with a special focus on certain countries like Europe, North America, and South America. And we have seen, Dr. Noura, in your presentation, the initiatives which was quite fruitful initiatives in Italy, in UK, in Quebec, in Canada, and so forth. The question is why, with all this compelling evidence, we are reluctant or we are delayed in our healthcare system in the kingdom to make these decisions of implementing the MenB in our in our vaccination programs. So why? The big why.
Honestly, like she said, we don't really know, but I do believe that weak surveillance, the fact that, like they said, most hospitals aren't equipped to know which serotype, makes us slower to move. If we know that serotype B, for example, was common and prevalent, then we might add it, or we might add the vaccine as a regulation. But the weak studies, again, if you Google the literature, there aren't a lot of studies about meningococcal disease in Saudi Arabia. So I think this could be the reason. We're just taking the recommendation that comes from the CDC. And like Dr. Muhammad said, meningitis B was more of a suggestion there.
Okay. Right.
I can add something also. Our culture is always resistant to change. I don't know why. Maybe this is the cause. Although we are seeing that changing, as we said, it's not only, we usually follow the CDC and North American guidelines, although MenB was not that there before. It was in Europe mainly. Our system, I don't know why by default we are always following the North America, although the CDC was not even recommending the men CWY in children, although in our national immunization program it was introduced from 9 months of age. In their immunization program they are taking it at 11 and 12. We have to consider this changing in the epidemiology and what we have endemic here. Also, our risk factor, our risk group is different than their risk group. We have here more patient of sickler, more patient of thalassemia who's having functional or anatomical asplenia. We have more gathering here with Hajj and Umrah in school. So I think maybe we have to take this initiative to start or to introduce this vaccine or any preventable. I'm not just talking about MenB vaccine. If anything that can be prevented, why we just wait until we see the consequences and the complication, then we think. We have to be proactive than reactive.
Yeah. Well said, Dr. Anura. Thank you so much.
I have one point, Dr. Ashraf. So I agree with Dr. Sarah about like lack of data here, but I would like to add also lack of molecular diagnostics. So if we look at the PCR and the meningitis multiplex, you will not find it in any hospital. You will find it in selective hospitals.
Yes.
And that's like super helpful when you diagnose a meningitis. It's a diagnosis within 5 minutes. You will know what you are dealing with, and you start de-escalating the antibiotics, preventing resistance, focusing on what you have. Okay. And this is also will help us to initiate and developing our own studies in that center.
Absolutely.
So when we have like multiple centers saying the same thing, the same serogroups, so I think this is the time to change.
Absolutely.
Yeah.
The wind of change. Yeah, thank you so much. Because of the time constraint, we are going to have only one question, and I would like to forward this question to Dr. Sarah, and this will be discussed also by all the panel, because it's a very important question. Can we predict the epidemic trend in Saudi Arabia in the future? This is a broad, wide question.
Yeah,
Dr.
this is
Sarah.
actually a very difficult question because, like we said, the surveillance aren't there. But from the, again, the epidemiology is actually related to the spread of Islam. And now we're having more Muslim people that come from Europe and the US, where again, serotypes or specific serotypes is more common. Before it was more from the Africa and Indias, and that's why we had serotype A and W, which was more common at that area. So there's also the fact that Saudi Arabia is now a place for tourism. And you're gonna have people from all over the world and not just during the pilgrim or the Hajj season or Umrah. So I do believe that surveillance is necessary. A reporting system should be known for all doctors, not just ID doctors or family physician. Everyone should know what to do if they suspect or they heard someone had a contact with patient with meningitis. And everyone, of course, should be aware that there is a vaccine. So if I'm traveling somewhere, even if it's for recreational reasons, there is a vaccine or protection that I can use.
Excellent. Okay. Any other additions from the audience? You have a question?
I have a question for the audience. Do you know what to do, what the MOH is doing for the cases that was reported as meningitis? Do you know what is the further steps that's happened? Anyone, even from the online?
Online, they are not in contact with us. But I think it's wise to give us the answer as well.
Anyone?
No,
Anyone should report that to health hospital director, and hospital director should report that to there is a directorate in each region for infectious disease, and it should be reported within the first 24 hours, at least maximum 24 hours actually, immediately, especially meningococcal meningitis.
All type of meningitis. There is a list of reportable disease
Yes.
that all of you should know. Okay, whenever you face any one of these reportable disease, you have to notify your infection control department in your hospital. Okay, and there is an MOH paper to be filled with basic information and who's the contact number, the isolation. Information and everything. So after the infection control, they will contact and they will enter this data in HISN. There is a program that is developed by MOH. It's called HISN for reporting such cases. They are collecting all this data and also communicating with the contact with these cases, the index case and their contact, and they may provide also a chemoprophylaxis for those patients. So your part is to notify the infection control and to report these cases, okay?
Okay, so because of the time coming to the end of these sessions, it was really fruitful and wonderful by your attendance and by your contributions. And I would like to thank on your behalf, ladies and gentlemen, the colleagues, our guest speakers, Dr. Sarah Muhammad, Dr. Muhammad Samanoudi, and Dr. Noura Azhari for the wonderful contributions and enriching our scientific session today with a lot of updates and a lot of interactions. And I would like to thank all the audience here physically, and I would like to thank the 2,500 attendees virtually for their wonderful questions. In fact, I had many of them, but I couldn't get the time to stratify them to have enough time. So with this, I would like to thank you. And I would like also to remind you that this is the IMC Family Medicine Club. We are going to have another session, inshallah, next month. So stay tuned with us. And I would like to take the opportunity to thank the Saudi Society for Family and Community Medicine. And I would like special thanks to GSA Company for their wonderful contributions to enrich the scientific gathering with a lot of updates regarding hot topics and issues like meningitis. And I would like to thank also Multaqa Al-Khibrat for their wonderful organizations. And thanks for those who are attending from different cities. In fact, we are privileged to have you here. And I would like to say to you, good night till we meet again. Have a wonderful night. Assalamu alaikum wa rahmatullahi wa barakatuh. We will have